Bismillahirrahmanirrahim. Assalamu alaikum students. I hope all of you are fine. Let's begin with the part 2 on the drugs used for the treatment of Parkinson's disease. First, we'll have a quick recap on what we did in the previous lecture. As you can well appreciate the signs and symptoms of Parkinson's disease, there is a typical mask-like face in which the person is giving no expressions. There is stooped posture, there is rigidity and flexed elbows and slightly flexed hips and knees. Similarly, there is trembling of extremities and there is small fascinating small stepped gait. There is reduced arm swinging and forward tilt of trunk. So these are the typical signs and symptoms of Parkinsonian disease. Then we discussed about the classification of anti-Parkinsonian drugs, in which we discussed that basically either you are going to increase the concentration of dopamine by giving dopaminergic agonist, or either you are going to decrease the concentration of acetylcholine by giving anticholinergic drugs. So, Parkinson's disease is basically because of the imbalance of cholinergic and dopaminergic neurons, and the etiology of this disease can be of any reason. It can be hereditary, it can be trauma, it can be any toxins, which we have discussed in detail. So we talked about our main drug, which was levodopa. We discussed about its mechanism of action, its pharmacokinetics, and in this lecture we'll be covering the adverse effects of levodopa and its drug interaction and the other drugs which are given for the Parkinson's disease, and most importantly why we give the combination of levodopa with carbidopa. This is a very important question, and students, for today's assignment you have to do why levodopa is combined with carbidopa. What are the pros and cons of this combination? So in the last lecture, there was a slide on the on and off phenomena, which I could not tell in detail. So let's discuss about that first. As the name is indicated, on and off phenomena. So on means there is on periods of improved mobility, right? The patient is able to be mobile more often and he is more comfortable. The posture and the mobility is better when there is on periods, whereas off periods means that there is akinesia, there is loss of the movement. So on and off phenomena can be treated by giving a dopaminergic agonist, which is apomorphine. So regarding the on and off phenomena, as you can well appreciate in this graph, that as we give the levodopa, there is increase in the concentration of levodopa, and which leads to the increase in the period of mobility. So the symptoms are decreased and the patient has improved mobility. So when the levodopa levels start to decrease and there is a trough in the plasma concentration, the symptoms return to the period of immobility. So we say that this is on period in which there is improved mobility and off periods when there is immobility. So this is called on and off phenomena, which is seen with levodopa. We can also say that it's a peak and trough, and it is seen with the longer term use of the levodopa. So how we can decrease this thing on and off period? We can give longer acting dopamine agonists like apomorphine, or we can switch from the combination of levodopa to levodopa plus COMT inhibitors. This is a very important question, on and off phenomena. So you can say that on and off phenomena is seen in Parkinson's disease in the patients who are taking levodopa for a longer period of time. All right. So it is the basically motor fluctuations. So motor fluctuations leading to akinesia and dyskinesia is the period of off period, and on means good. So when the levodopa is working well and your symptoms are controlled, we say that is the on period. And off period is when the levodopa is no longer working well and the symptoms reoccur, like tremor, rigidity, and movement, slow movement re-emerge. So this is on and off phenomena. It's important from the university point of view as well. It can be related to the peripheral metabolization of levodopa, which is anorexia, nausea, tachycardia, hypotension, and psychiatric problems, in which we'll be discussing in detail what effects can it cause in the CNS. So we categorize the adverse effects into two: peripheral effects and CNS effects. So it can cause anorexia, nausea, and vomiting by stimulating the chemoreceptor trigger zone, and it can cause tachycardia and ventricular extrasystoles by the effect of the levodopa but through the dopaminergic receptors on the heart. Similarly, it can cause hypotension, mydriasis, which is due to its adrenergic stimulation. There is blood dyscrasis, in which there can be seen hemolytic anemias. Then we have positive Coombs reaction. And at this point, if you recall from your chapter on the cardiovascular system, the positive Coombs test was also seen with another drug, which is alpha methyl dopa. So this is a drug similar to alpha methyl dopa, as the name is indicating. Alpha methyl dopa was a drug which was used in the treatment of hypertension, especially in those females who are pregnant. So it was a drug of choice in pregnancy-induced hypertension. Then regarding its adverse effect, there is a unique adverse effect in which their saliva and urine becomes brownish in color because of the melanin pigment which is produced from this catecholamine oxidation. Then the effects which are related to the CNS are visual and auditory hallucinations, as well as abnormal involuntary movements which are called dyskinesias. These effects are opposite to that of Parkinsonism and reflect the overactivity of dopamine and the receptors at the basal ganglia. So, as if we are giving the patient the treatment for the Parkinson's disease, which is the levodopa, and if it is given for a prolonged period of time, it can cause increase in the overactivity of the dopamine. So at this time we need to give a break. At which we discussed previously that we can give drug holidays to improve the adverse effects of levodopa, or we can give another drug which can improve the level of levodopa. So levodopa can also cause mood changes, depression, psychosis, and anxiety. So if we discuss about the adverse effects of levodopa and drug interactions, levodopa, if given with MAO inhibitors, it can cause hypertensive crisis due to the increased catecholamines, because MAO inhibitors, they all decrease the metabolism of the other catecholamines, and since it is also increasing the blood pressure, and similarly MAO inhibitors also increase the blood pressure, it can lead to hypertensive crisis. And if we give levodopa with pyridoxine, which is vitamin B6, then it can lead to diminished effect because of increased peripheral metabolism of this drug. So in psychotic patients, you have to be very careful because levodopa exacerbates these symptoms because it is prone to cause hallucination in the patients. It can also cause increase in intraocular pressure, and cardiac patients should be carefully monitored because of the possible development of cardiac arrhythmias. So remember students at this point that the drug which has unusual variety of adverse effects, it is most likely candidate to be asked in the exam. So levodopa's mechanism, it's rational to combine levodopa with carbidopa, and its adverse effect. Altogether, all are very important university questions. So we basically contraindicate the antipsychotic drug in the patient who is also a diagnosed case of Parkinsonism. And therapeutic uses, the levodopa is used for the treatment of Parkinson's disease, and especially it decreases the rigidity, tremors, and other symptoms of Parkinsonism. And once again, I just told you that the rationale for combination of carbidopa with levodopa is frequently asked question in exam as well. So let's talk about another group of anti-Parkinsonian drugs, that is entacapone and tolcapone, which are basically COMT inhibitors. COMT is an enzyme basically which is responsible for the metabolization of levodopa, and it converts levodopa into 3-O-methyl dopa, and it is a minor pathway for levodopa metabolism. We have already discussed the main pathway for the levodopa metabolism. But the important point here to remember is that when the levodopa is metabolized, it is converted into 3-O-methyl dopa by this COMT enzyme. So this 3-O-methyl dopa, which is a metabolite of the levodopa, it competes with levodopa for active transport into the CNS. So if this metabolite is formed, then of course the level of levodopa which has to reach into the CNS will also decrease. So we need to give COMT inhibitors to increase the level of levodopa into the CNS. So this rationale is also very important. This can also be asked in exam. Why do we combine levodopa with COMT inhibitors? So if we inhibit the COMT enzyme, what is going to happen? There will be decreased plasma concentration of 3-O-methyl dopa, which was the important competitor for the levodopa. Then the increased central uptake of levodopa, there would be greater concentrations of the brain dopamine and reducing the symptoms of wearing off phenomena seen in patients with levodopa and carbidopa. So we can say that the on and off phenomena can be much better control if we give levodopa with its COMT inhibitors instead of levodopa and carbidopa. So regarding the pharmacokinetics, they are readily absorbed. The difference of these COMT inhibitors from that of the other drug is that it is not influenced by the food, as we discussed in the carbidopa and levodopa. It is bound to plasma protein more than 98%, and tolcapone penetrates the blood-brain barrier and inhibits the COMT in the CNS, and it has got a very long duration of action. So this is the diagram to show the metabolism of the levodopa by the COMT enzyme. It is forming 3-methyl dopa as I just mentioned, and the 3-methyl dopa then competes with the levodopa to reach into the CNS. So once we are blocking the dopa decarboxylase enzyme by the carbidopa, but the other problem is that we are also producing a metabolite 3-O-methyl dopa, which is a competitive inhibitor with the levodopa. So we also need to give entacapone and talcapone, which inhibits the enzyme COMT, and at the same time carbidopa, which is inhibiting the enzyme dopa decarboxylase. Thus the level of levodopa reaching into the CNS is more if we give the enzyme inhibitors rather than giving this drug alone. As we discussed initially, the bioavailability of levodopa is very less. So we need to give a very high dose of levodopa, or we need to combine this levodopa with various enzyme inhibitors. Then if we move on to our third group, that is the MAO-B inhibitors, in which we have SELEGILINE and RASAGILINE. And remember students, MAO type A is metabolizing norepinephrine and serotonin, which is used for the treatment of depression. And similarly type B are metabolizing dopamine. So in Parkinson disease we give dopa being type MAO type B inhibitors. So this is its mechanism of action. Dopamine metabolism by MAO-B. So we are inhibiting so that there is increased level of dopamine. Then another group is bromocriptine, which is a dopamine receptor agonist, and it is given for 2 to 3 months. And the side effects of this drug basically limit its utility for the treatment of Parkinson's disease. The actions of bromocriptine are more or less same as that of levodopa, and except that hallucinations, confusion, delirium, nausea, orthostatic hypotension are more common, whereas dyskinesia is less prominent. So all these adverse effects were also experienced with levodopa, but remember the severity of these symptoms is more in the case of the bromocriptine. So in psychiatric illness, bromocriptine and levodopa can worsen the condition. So both are contraindicated. Similarly, in cardiac issues, it can precipitate MI, so we need to be very careful. And there can be worsening of vasospasm, and in peptic ulcer, there can be worsening of the condition. It can also lead to pulmonary and retroperitoneal fibrosis. Since it is an ergot-related compound, it can also cause erythromelalgia and pulmonary infiltrates. Students, note down at this point, this is a very important MCQ. You can be asked which of the following drug causes erythromelalgia or pulmonary infiltrate. So it is no other than bromocriptine. Since bromocriptine is a ergot derivative, so it can cause these adverse effects. So at the end of this lecture, I am sharing a quick recap so that you can remember the pathophysiology of Parkinson's disease. As you can see, it's the imbalance between acetylcholine and dopamine. So our main aim is to increase the level of dopamine or decrease the level of acetylcholine. So this is another diagram to show the classification of the various anti-Parkinsonian drugs. As we have already discussed, the levodopa metabolized by the enzyme COMT. So we are going to give the inhibitors TOLCAPONE and ENTACAPONE, which inhibit the metabolization of the levodopa. Similarly, levodopa when converted into dopamine, and the dopamine is metabolized through MAOB. So we are giving the MAOB inhibitors like SELEGILINE. And same as the levodopa, there is mentioned there is on and off phenomena, and there is increased risk of psychosis, and it also causes effects on the CNS like hallucinations, and there are peripheral adverse effects as well. So you need to, it's just a quick recap to show how the drugs are acting at the various levels. This diagram is also showing mainly the synthesis of dopamine, how it is synthesized in the dopaminergic nerve terminal, and how it is then dopamine is metabolized by the MAOB, or it is degraded by the COMT, or it is released and it binds to the dopaminergic neurons, so dopaminergic receptors. So this is the various sites of action of the anti-Parkinsonian drugs, and we have already classified them and studied their mechanism and adverse effects in detail. So you can just go through this diagram and have a quick recap of the anti-Parkinsonism drugs. So thank you very much, students, for being with me and listening to the lecture. Kindly submit your assignments which was given to you in mid of the lecture and submit it on your respective WhatsApp groups, and try to write down your own answer instead of copy pasting your colleague's question answer. So we are thoroughly going through the assignment, so be careful, and I tried to make a very easy version of this topic, hence it's a very important question from the examination point of view. First of all, you can be asked about the rationale for combining levodopa with carbidopa, levodopa with COMT inhibitors. Then the adverse effects of levodopa and drug interactions are very important. Similarly, the contraindications of levodopa. Then you can be asked about the adverse effects of bromocriptine, which I just mentioned, that since it's an ergot derivative, so it may have adverse effects related to the ergot compounds as well. So most important of this is the classification of the anti-Parkinsonian drugs. And students, we have already given you the classification handouts on the various systemic pharmacology like of the CNS, CVS, respiratory system. Kindly go through these once the topic is finished and do the classification from your handout. It will be very beneficial to you. So we are left with some movement disorders. So I'll be covering that in another lecture. So with that, we end today's lecture. Thank you very much. Allah Hafiz.